Hello, I'm Dr. Lalit Shimpi. I'm a consultant gastroenterologist and hepatologist practicing in Pune, and I'm attached to Jahangir Hospital as Chief Therapeutic Endoscopist and also attached to Dinanath Mangeshkar Hospital in Pune, and I've been practicing for the last 15 years or so. Let us come to management of drug-induced liver injury, and we can have a look at some of the guidelines. What I can discuss is the European Association guidelines for management of drug-induced liver injury. So, as I had also mentioned in my earlier talk, management of drug-induced liver injury is generally symptomatic, and one has to monitor the patient very carefully to see whether his symptoms as well as his liver enzymes, biochemistry, as well as clinical features are improving with stopping the offending drug or not. Most people will do well with symptomatic therapy only and liver protective agents, while if patients are showing signs or symptoms or biochemical features of liver cell failure, then early referral to a liver transplant unit is recommended, especially in our country where you have non-paracetamol induced liver injury being most common. How do you prevent drug-induced liver injury? Maybe by being more vigilant, especially during preclinical drug development trials, clinical trials, really looking at adverse events and serious adverse events and trying to find out whether they are because of the offending drug that is being tested. So, in the preclinical stage of development, I think this is something that is very important and should not be neglected, and these results should always be published transparently so that we are sure about the drugs that we are giving and whether they are safe or not. The other thing to prevent drug-induced liver injury is, especially if you are planning to give a drug which may or is known to cause drug hypersensitivity or allergic reactions or a direct drug-induced hepatotoxicity, then it makes sense to have a baseline liver function test done, and there hopefully should be, especially if the liver function test or baseline is normal, then if the patients do develop symptoms, you need to monitor them. And if the patient is in a category where he has mild transaminitis, or there is an underlying chronic liver disease, or underlying cirrhosis, or underlying immunosuppression, for example, people who have HIV infection or co-infection, these are the ones in which you need to be more vigilant when you're starting drugs so that you can prevent drug injury and treat it early if it does happen. Acetaminophen toxicity in our country is not very common. It's more common in the West, but largely the treatment for that has been standardized with N-acetylcysteine. And those, especially who are presenting early within 24 hours of acetaminophen ingestion, the recent trials have shown that the oral protocol, where you give 140 milligrams per kilogram of N-acetylcysteine orally, as a loading dose, and then every 4 hourly you give 70 milligrams per kilogram as an oral dose for the next 17 hours or so. So this is the oral protocol which is now recommended more than the intravenous one, which was the 21-hour protocol, which was followed or which is followed, especially if the patient is not able to tolerate the oral protocol. So you give 150 milligrams per kilogram as a loading dose IV, and over the next 1 hour you give 50 milligrams per kilogram, and then for the next 17 hours you give 100 milligrams per kilogram as a continuous infusion. So that is about acetaminophen. In non-acetaminophen toxicity, there are no specific drugs. In severe injury to the liver because of known medications, and if the patient does have acute liver failure or encephalopathy or a very prolonged prothrombin time and you're expecting liver failure to be there, then one can also try, and there are trials of N-acetylcysteine therapy even helping in these kind of scenarios. There are also other intravenous agents, like for example, glutathione is available intravenously. You can try giving these agents along with other supportive medicines, maintaining hydration, maintaining blood sugar levels, because many of these patients are prone to hypoglycemia, managing acidosis. So I think all of these are supportive measures that one needs to take. If there is some evidence of hypersensitivity, so for example, the patient, in addition to the hepatitis, has fever, rash, or eosinophilia on hemogram, then you are looking at probably drug-induced autoimmune hepatitis. And if especially the disease is severe, then one should consider corticosteroid therapy as an additional treatment to supportive treatment that you are giving. Patients who present with cholestatic features, one can always add up skin emollients or agents such as hydroxyzine, which is also available as Atarax, or diphenhydramine, any of the antihistaminic agents to reduce the pruritus. You can also use bile acid resins, for example, cholestyramine, or in severe cases, you can use rifampicin if that is not obviously the cause for the drug-induced liver injury in the first place.